subscribe to my YouTube channel Meditate Literature Mandala and also hit the press bell icon whenever I upload my video get notified.
The learning objectives for this topic will be the introduction, what is it, how does it look, what is the capacity, the external features, supports, that is the ligaments that help to keep the urinary bladder in position, interior of the bladder, arterial supply. Now, introduction. As we all know that urinary bladder is a reservoir of urine. It stores the urine and voids it at regular intervals. The location of urinary bladder is, it lies in anterior part of pelvis. It lies within the pelvis, immediately behind pubic symphysis and in front of rectum in males, whereas in front of uterus in females. So this urinary bladder in case of males lies between pubic symphysis and rectum, whereas in females it lies between pubic symphysis and uterus. Variations in position. With amount of urine it contains, it varies. If it is empty, then it lies entirely within the lesser pelvis. But if it is distended, then it expands upward and forward and reaches into the abdominal cavity. Other variation is with age. In children, it is abdominopelvic. It lies within the abdomen as well as pelvis, even when it is empty. After puberty, it reaches the pelvic region or into the lesser pelvis. At the age of 6 years, it starts descending into the lesser pelvis, and after puberty, it reaches completely into the pelvis. Shape of the urinary bladder. When it is empty, it is tetrahedral in shape. Tetrahedral meaning having 4 surfaces, whereas if it is distended or filled, then it is oval. Capacity of urinary bladder is, in adult male, is approximately 120 ml to 320 ml. That is, the mean capacity is somewhere 220 ml. At 220 ml or beyond 220 ml, there is a desire to micture it. Usually it is emptied between 250 to 300 ml. Up to 500 ml, it may be tolerated. But beyond this, it causes pain due to the distension of its walls. And further, beyond 800 ml, micturition is not under voluntary control. Coming to the external features of the urinary bladder, it has got an apex, a base which lies exactly opposite to the apex, that is towards the rectum. Then it has got a neck which is directed downwards and has a urethral opening. It has got 3 surfaces, the superior surface, 2 inferolateral surfaces on each side, and 1 free surfaces. 4 borders are there. One is the anterior border, that is between the 2 inferolateral surfaces. 2 lateral borders are there, that is between superior surface and inferolateral surface, and 1 posterior border is there, that is between superior and base or this is another image showing the surfaces and the borders. This is the superior surface, the inferolateral surface, posterior surface, neck, and the apex. Borders, as you can see, anterior border between 2 inferolateral surfaces, 2 lateral borders, and 1 posterior border. Talking about relations, to start with apex. Apex lies anteriorly. It lies posterior to the upper margin of pubic symphysis, and it gives attachment to median umbilical ligament that connects it to the umbilicus. Median umbilical ligament is a remnant of allantois or urethra. Then coming to base, which lies posterinferiorly towards the rectum. It has got 2 angles. The superolateral angles are joined by the ureters. That is, the ureter enters the urinary bladder at the superolateral angles of the base. In males, the upper part is separated from rectum by rectovesical pouch. Whereas in lower part is separated from rectum by the presence of vasa differentia and seminal vesicles, and the space between vasa differentia, the region between vasa differentia, is separated from rectum with the help of rectovesical fascia or fascia of Denner. In females, if you talk about the relation of the base, it is separated from the cervix of the uterus. As we know, behind the bladder in females lies uterus. So it is separated from the cervix of the uterus by uterovesical pouch or vesico-uterine pouch. Coming to the neck, this area is the neck, the inferior region. It is situated where the two inferolateral and posterior surfaces meet. This region forms the neck. It lies approximately 3 to 4 centimeters behind lower part of pubic symphysis. As we can see in the image, it is pierced by internal urethral sphincter. In males, if you talk about the relations of the neck, this neck rests on the upper part of prostate gland, where the smooth muscle fibers of the bladder wall are continuous with those of the prostate gland. We can see the continuation of the smooth muscle fibers, and this neck is resting on the prostate gland. Talking about females, it is related to urogenital diaphragm. Here we can see the muscles of the urogenital diaphragm. So this neck is related to the urogenital diaphragm. Next is the superior surface. It is triangular in shape, as we can very well appreciate. It is bounded on each side by lateral borders and posteriorly by posterior border. The relations of superior surface in males, it is completely covered by peritoneum. We can see a fold of peritoneum. It's completely covered by peritoneum, which separates it from sigmoid colon and coils of terminal ileum. In females, in the anterior part or most of the part of the superior surface is covered by peritoneum, except the small area near the posterior border. This is related to supravaginal part of uterine cervix. Here this peritoneum is reflected and forms utrovesical. Inferolateral surface. Coming to inferolateral surface, on each side it slopes downward, forward and medially. It is separated from each other by the anterior border. This is the anterior border. This is the posterior aspect of the bladder. This is the anterior aspect. This is the anterior border, apex, and this is the base of the urinary bladder. So it is separated from each other by anterior border, from superior surface by lateral borders. It is devoid of peritoneum in male and female. Relations of inferolateral surface. In front, it is related to, you can see, pubic symphysis. Then there is a space between pubic symphysis and urinary bladder, that is the retropubic space. So in its anterior relations lies pubic symphysis, retropubic space, and puboprostatic ligament in males, ligament extending from the back of the pubis to the prostate, puboprostatic ligament. Similar structure in female is known as pubovesical ligament. It reaches from pubis to the neck of the urinary bladder in female. So these are the anterior relations of inferolateral. Talking about posterior relations of inferolateral surface, in its upper part lies obturator internus muscle, and in its lower part lies levator ani muscle. Lateral ligament and false posterior. True ligaments, as I've told you, formed by condensation of pelvic fascia, and they are supportive in function. So first talking about lateral ligament. As you can see, these are the lateral ligaments. The one lying laterally, they extend from inferolateral surface of tendinous arch of pelvic fascia to the inferolateral surface of the urinary bladder to the tendinous arch of pelvic fascia. Lateral. Lateral puboprostatic, they extend from anterior end of tendinous arch to upper part of posterior sheath. Extend from anterior end of tendinous arch to the upper part of posterior sheath. They are directed downward and medially. Talking about medial, they extend from pubic bone to the prostatic sheath, near pubic symphysis to prostatic sheath. These are directed downward and backward. So these actually form the floor of the retropubic space or the space of Retzius. In female, similar facial bands are known as pubovesical ligaments. They end around the neck of the bladder. Next is median umbilical ligament. Median umbilical, as we've already discussed, extends from the apex to the umbilicus. It is a remnant of urachus, and it maintains bladder in position anteriorly and posteriorly. Posterior ligament, they are two in number. As you can see, they are two in number. The extent is from the base of the bladder, the posterior surface of the bladder, base of the bladder to the lateral pelvic wall. These are directed backward and upwards. They enclose, can you see, these are the vesical venous plexus through which the venous drainage of urinary bladder takes. Coming to the false ligaments, as I've mentioned, they are the folds of peritoneum. They do not provide any support. They are not formed by the condensation of pelvic fascia. They are just the folds of peritoneum. So there are 7 in number. 3 lies anteriorly, 1 lies in the median plane, 2 medially, then 2 laterally, and 2 posteriorly. Median umbilical fold, it is found over the median umbilical ligament. Two medial umbilical folds found over obliterated umbilical. On each side we have got false lateral ligaments. Again, these are the reflection of peritoneum from the bladder to the side of the pelvis. So these form the floor of paravesical fossa. This is known as paravesical fossa. So this forms the floor of paravesical fossa. A pair of false posterior ligaments. These are the sacrogenital folds. These extend from the side of the bladder posteriorly on either side of the rectum to the anterior aspect of third sacral vertebra. So these are the false peritoneal ligaments, which are nothing but the peritoneum. Talking about interior of the bladder, in empty, the greater part of the bladder shows mucosal folds known as rugae. Some part of the bladder, a triangular area, is smooth. Here, no rugae are found because the mucous membrane is firmly bound to the underlying muscular cord. This area is known as trigone. This trigone has got two posterior-superior angles and one antero-inferior angle. The two posterior-superior angle shows two orifices known as urethral orifices, where the two ureters open, whereas the antero-inferior angle shows an opening known as internal urethral. These are the two openings of ureter, and this is the opening of internal urethral orifice. Uvula vesicae, it is nothing but elevation, slight elevation in mucous membrane just above and behind the internal urethral. It is due to this is uvula vesicae. Uvula vesicae. Then there is a ridge that connects the two posterior-superior angles, or the openings of the two ureters. This ridge is known as interureteric ridge, lying between the two ureters. Interureteric ridge or interureteric crest or bar of Mercier. This forms the superior boundary of the trigone and it connects two ureteric orifices. It is formed due to continuation of inner longitudinal cords of the two ureters into the bladder wall. Then you can see another ridge connecting the ureteric orifice to the uvula vesicae. This is known as Bell's bar. This is produced due to the longitudinal fibers of the ureters. Coming to the arterial supply, the principal arteries that supply the urinary bladder are the superior and inferior vesical artery. Superior vesical artery and inferior vesical. Both are the branches of anterior division of internal iliac artery. Other arteries that supply are obturator inferior gluteal arteries, uterine and vaginal. Again, the branches of internal iliac. Venous drainage. Here veins do not follow the arteries. They form complicated plexus or the infralateral surface near the prostate called the vesical venous plexus. This venous plexus drains into internal iliac. Lymphatic drainage is through external iliac lymph nodes. Some of the vessels drain into internal iliac. Nerve supply. Nerve supply, motor innervation and sensory. So motor innervation, we've got parasympathetic, sympathetic and somatic. So parasympathetic fibers are derived from S2, S3, S4 segments of spinal cord. These are motor to detrusor muscles but inhibitory to the internal urethral sphincter. On the contrary, the sympathetic fibers, these are derived from T12, T11, T12, L1, L2 segments, that is thoracolumbar. These are inhibitory to detrusor as compared to parasympathetic, which were motor to detrusor. These are inhibitory to detrusor and motor to internal urethral. Somatic fibers, these are derived from pudendal nerve, S2, S3, S4 spinal segments. These are motor to external urethral. Sensory innervation, majority of the sensory fibers, they run along parasympathetic. Some also run with sympathetic fibers. Pain is carried by both sympathetic and parasympathetic. Coming to the clinical anatomy, suprapubic cystotomy, bladder is distended with 300 ml of fluid. As a result, the anterior aspect of the bladder that comes into direct contact with the anterior abdominal wall, and this can be approached without entering the peritoneal cavity.